Yes, and ladies and gentlemen, we are now officially on the third session, on the third plenary sessions, and this one will be led by Ibu Radendra Radia Handayani. What will it be about, Mbak Eta?
Okay, our moderator is Ibu Radendra Rodia Handayani. She is an experienced medical professional with extensive education, positions in pulmonary medicine, and a notable record of research in respiratory infections and tuberculosis, published in various medical journals. Currently, she works as Head of Education Coordination at Universitas Indonesia Hospital. And this third plenary session will bring the topic of clinical management of tuberculosis. So without further ado, please give applause to Ibu Dia Handayani.
Everybody in this last plenary in the 5th INATIME in Jogja right now. I'm so glad that until the last plenary, many participants still have a spirit to attend this last plenary. And in this plenary, actually this is a dream from clinicians, because in this plenary we will discuss about diagnosis and also treatment in TB, especially the current diagnostic tool and also the current treatment, and what already prepared or what already in the line of TB treatment development, or many new tools and also many new drugs. So in this plenary session, we will have three experts in TB diagnostic and also TB treatment from many centers. The first one from London, the second one from Groningen, and the last one from WHO Geneva. So even this is an online expert, but we have a very expert and who have many experience in their expertise. So I will invite the first speakers, Jody Phelan. Jody Emil Phelan is an accomplished computational biologist with expertise in analyzing large-scale biological data. He is proficient in programming language, developed tools like TB Profiler, NTM Profiler, and Malaria Profilers. He holds a PhD from LHATM, London School of Hygiene and Tropical Medicines, and currently as assistant professor in London School of Hygiene and Tropical Medicine, specializing in predicting drug resistance in tuberculosis, NTM, and malaria. And right now, Jody will discuss and also will present about us with the topic TB diagnosis and current development in new drug. And Jody will present from London.
Ibu, we are very sorry, but I think Jody hasn't joined the Zoom conference yet.
Okay, thank you. Jody has not joined to the Zoom, so we will. The first speaker will be Ono Ackerman. Ono Willem Ackerman is a Dutch physician, experienced in pulmonary medicine and tuberculosis. His PhD with the topic in tuberculosis and its sequel. He worked as pulmonary physician at University Groningen and TB Center Beatrixshoort actively involved in guideline committees, TB consultancy, and also international TB networking. Have you ready? Ono? Ono will present
Yes,
to
thank you.
us about
Yes,
TB treatment and current development in new drug.
Yes, thank you so much. Thank you for the invitation as well. And I'm here, and I just wondering, should I share the slides myself, or will you do it? Because I sent a latest version just recently, but I can share if you prefer. I will do so. And I hope you can see my screen now. Can somebody confirm that they can see my screen?
Okay.
You can see my screen now, is that correct or
Yes.
not?
Yes, your
In
side already
in the slides as well.
share.
Yeah, okay, very good. So it's about TB treatment and current developments in new drugs. And I will guide you through some of the latest developments for the TB treatment as well. And let me see if I can. And as though I'm still in Groningen at the moment, I was at UGM a couple of years ago, so I wanted to share this photo with you as well. So I have visited you, but next time I will be there present if possible. But I wanted to discuss the treatment of TB, the developments of TB, and the urge for newer developments and newer drugs. And this probably you have seen before the last couple of days. It's the Global TB Report of 2022, and you know all these details, but I wanted to share some important topics, and that's especially about drug-resistant TB, that it remains a public health crisis. And what is really shocking is that only about 1/3 of the people with drug-resistant TB have access to treatment which they really need. And the burden remains the same or even increase a little bit in recent years. And as said, only 33%, around 33% receive the proper treatment. And the treatment success rates remain really low by only about 60% globally. So it's a really global threat, the MDR-TB. And why is that so important to stress out? And this, I think it's a very important overview of the development of anti-TB drugs, which was published 13 years ago. So there are some new developments, but I will discuss it with you later. And what we see is that in the 1940s, 1950s of the last century, there were many new drugs developed against TB. And for sure, everybody knows them. And in the 1970s, the British Medical Research Council did their large studies to develop the current TB treatment regimen with rifampicin, isoniazid, pyrazinamide, at that time streptomycin, but nowadays with ethambutol. And since then, we only have 2 or 3 now new TB drugs on the market. And there were some repurposed drugs, which I won't discuss today, but they are the later generation quinolones, especially, and injectables. And of course, the linezolid as well. But I think this is a recent paper in the New England Journal of Medicine about the development and treatment of drug-susceptible tuberculosis. And why is that so important? Because still 50 years after the large trials of the BMRC, we still have the same regimens for 6 months. So we need to, we have an urgent need to shorten the TB treatment for drug-susceptible TB. And this is a really important paper because it's the first to show that a 4-month treatment regimen is actually successful, or at least the same success as the current treatment. It was published recently in the New England, 4 months of rifampicin, and there was 3 groups. The control group with the current standard treatment of 2 months, rifampicin, isoniazid, pyrazinamide, and ethambutol, compared with 2 months of rifampicin, moxifloxacin, isoniazid, and pyrazinamide, followed by 2 months of rifampicin and moxifloxacin. And the control group, other control group, was the rifampicin with isoniazid, pyrazinamide, and ethambutol. And the ethambutol and the moxifloxacin were the differences between the comparative groups. And I think what we see here is that the control group of 6 months treatment, they have a favorable outcome, a success percentage of 85% compared to the rifampicin moxifloxacin group for 4 months of 84.5%, which is non-inferior to the control group. And the rifampicin group with ethambutol instead of moxifloxacin had a little lower treatment success, but still quite high, 82%. And favorable outcome are more or less the same as expected, of course, and there were also some non-accessible participants, which is clear if you do a large study like this. Of course, except for efficacy of new treatment regimens, safety outcomes are important as well. And I think what you can see on this slide is that the rifampicin moxifloxacin comparative group as more or less the same grade 3 or higher adverse events to the control group, and the rifampicin with ethambutol group as even lower percentage of high adverse events, which makes sense because moxifloxacin we know is more toxic than ethambutol. In general, toxicity is quite acceptable in all 3 groups. The only problem for rifampicin is that it should be accessible to the countries, which at least in Western Europe is a problem because we don't have access to rifampicin and we still have to give our patients the 6 months treatment. But at least there are some developments ongoing which are promising. And I know at least in Europe, we are really busy to get the license for rifampicin so we can use it in general. So the 4 months treatment of drug-susceptible TB is promising, and I know in the next presentation or the presentation afterwards, depending on the new program, the shortening of treatment regimens will be discussed further. And because I think it's also important to mention about the SHINE trial for children, also 4 months of treatment, which is a really promising study as well. And I wanted to discuss the developments in the treatment of drug-resistant TB and especially the MDR TB, because as we saw, that is a real big challenge nowadays in the TB, ongoing TB epidemic. And this was published more than 3 years ago, highly drug-resistant pulmonary TB, the treatment by Francesca Conradi and her colleagues. And it was a study in MDR and XDR TB patients already on treatment before and failing regimens or XDR, but you can see the numbers are not really high, and especially not for MDR TB, but for XDR because they are easier to include in a new treatment regimen for only 6 months. And it was 6 months consisting of bedaquiline with a standard treatment of 2 weeks loading dose of 400 milligrams once daily, afterwards followed by 3 times a week, 200 milligrams, the pretominate, which was the newest anti-TB drug, and the linezolid. And the linezolid was a dose quite high, 600 milligrams twice daily, and sometimes followed by 600 milligrams once daily, depending on the adverse events. And you can see that treatment success, the favorable treatment outcome in the patients is quite high, especially if we think it's an MDR or an XDR TB patients. So the treatment success is reaching 90%, and overall it's actually 90%. Unfavorable outcome is quite low with 3 patients, and it's around 10%. And of course, we know that from the treatment drugs, the anti-TB drugs in this treatment regimen, especially with a high dose of linezolid, there was some fear of high adverse events. And you can see that especially based on the linezolid regimen, there were high toxicity rates, adverse events in all patients receiving the treatment of linezolid twice daily, 600 milligrams, or once daily, 1200 milligrams, which we know because it's extremely high, and normally it's only given for 2 to 4 weeks. And of course, afterwards, they were thinking, shouldn't we lower the dose of the linezolid? However, also, apart from the adverse events, also the higher grades of adverse events, grade 3 and 4, were actually quite high, more than 50%, which is, of course, leading to stopping the treatment, which we don't want. So based on these results, they started the new trials with lower doses of linezolid. And I think this is more or less the next study, or the same study. It's about the 600 milligrams as well, but then compared to 26 weeks of linezolid versus 9 weeks of linezolid. And that was based on the toxicity of the previous studies. And what you can see is the favorable outcome are still quite high, but for the 9 weeks of linezolid, it's a little bit lower than the 26 weeks of linezolid. Unfavorable outcomes are more or less the same, because that makes sense, of course. And even more important is, of course, the adverse events in both groups. And what we see then is that the adverse events, as expected, are considerably lower in the groups treated shorter with linezolid, except for the 600 milligrams once daily, which is interesting and important, because then we can see that perhaps half the dose of the previous linezolid dose of 1200 milligrams, so now 600 milligrams once daily linezolid, might be effective without extra toxicity. And that was part of the other TB practical study as well, as a 24-week all-oral regimen, of course, as well. And what they did was the standard care group, based on the previous standard MDR-TB treatment regimens, quite long weeks, comparing them to the BPOL regimen, which is the lowest regimen in this slide, and compare them with 2 other groups, the BPOL-M regimen, moxifloxacin, and the BPOL-C regimen, which is the BPOL together with clofazimine. And what we see here, and this is the slide, and the results are in 2 slides, actually. You can see here the standard group has a success percentage of only 47% compared to the BPOL-M group of 76%. And by that, of course, the unfavorable outcome is comparable with the treatment success, only in the different ways. So the unfavorable outcome for the BPOL-M regimen is clearly much lower. And if we compare it to the BPOL-C and the BPOL, just the normal BPOL regimen, you can see that favorable outcomes for the BPOL-C and the BPOL regimen are lower than the BPOL-M regimen. And you can see they are 72 and 66% for the intention to treat population, and per protocol they were quite high, 90 to 88%. But the intention to treat population, I think it's more important because it's comparable to the real life situation as we know it as clinician. And you can see the BPOL-M regimen had 76%. So the BPOL group was quite a bit lower than the BPOL-M regimen. And this is a very difficult slide to read, and it's more or less about, of course, about the toxicity, and my apologies that I didn't make it more clear, but it's a long list of serious adverse events. And you have to believe me that the BPOL-M regimen had only 19% of the patients with a grade 3 or more adverse events within the 72 weeks after the start of treatment. And that is the lowest compared to the standard group, which was 59% and 32% for the clovesamine group, and the BPOL group had only 22% of, which was more or less comparable to the BPOL-M. Based on all these large studies, the WHO developed new guidelines for the treatment of MDR-TB, and it was published at the end of 2022. And for the first time, the 6 months all oral regimen with BPOL or BPOL-M was advised as the first choice. And BPOL-M is clearly only possible if there is susceptibility for the later generation quinolones. And it's preferable above the 9-month oral regimen for MDR-TB, also known as the Bangladesh regimen, which was developed by Armand van Deun more than 10, 15 years ago. And the longer regimens for MDR and rifampicin-resistant TB are now the lowest in the order of choices for treatment of MDR-TB. So in the recent years, we have a large difference in treatment for MDR-TB based on the new drugs of bedaquiline and pretominate. So 2 of the 3 new drugs, because the delamanid is there as well, made a complete game changer for the treatment of MDR-TB. Treatment duration is 12 months or longer, shorter, preferably. And there is still lots of research ongoing. And this is a slide from the working group on new TB drugs, and probably you know it. But as you can see, there is quite a lot of new compounds and new drugs in development. And as you can see, there are compounds in discovery, and then they will be chosen by the companies discovered. So that's what they call lead optimization. And you can see there are some already in that program. And from that point onwards, we go to the preclinical development. And there are some compounds already in those phases of research. And if they're still seem to be well tolerated and efficacious, they will continue with the clinical development. And then you, of course, have the phase 1 to phase 3 studies. And most studies are still in phase 1 and phase 2 for the clinical developments. And hopefully they will give us some more choices and a completely different presentation in 5 years from now on. And what is even more promising is that there are more large groups looking on new compounds and new TB drugs. And this is for Unite for TB. Most of you will know it. It's a large consortium based with clinical researchers and clinicians from many places around the world, but backed up by some pharmaceutical companies with their compounds, with their early stage or lead compounds. And part of their development plan is not only to see what kind of drugs can we develop, but also can we develop new studies to see if we have some kind of biomarker to see if they are effective or not, and to see if they can be prepared sooner for the market. And as you can see, there are some studies ongoing in phase 2A and phase 2B/C, and hopefully phase 3 studies will follow soon. And of course, you can see it later on the slides if you want to. So in summary, and that's why I wanted to finish my talk with, for drug-susceptible TB, it's promising that shorter treatment regimens based on the rifampicin for the adults, but also the SHINE trial for the pediatricians, MDR-TB and pre-XDR-TB, the 6 months BPOL or BPOL-M regimen completely changed the field of treatments and for MDR and pre-XDR-TB, and with highly successful outcomes. So they're really, really promising. And what is even more promising is there are many new compounds in the pipeline and new drugs actually in the pipeline. And there are already ongoing phase 2 studies, which is the latest phase before the large controlled trials for the new drugs in the pipeline. So it's a really promising field for the treatment of TB. And that was my talk. And I want to thank you for your attention. And this is a photo of my TB center. Any questions? I'm happy to answer. Thank you so much.
Okay, continue. Thank you, Ono, for the presentation. It's very interesting that we right now that there's so many drugs in the line of development. Yeah, so we can hope there's a new hope in the future. So we will continue to hear the presentation from Jody. Is Jody already joined the Zoom?
Hi there.
Okay. Okay. Please, Jody will present to us about TB diagnosis and current development in new drug. And again, I will introduce. Jody is an accomplished computational biologist with expertise in analyzing large-scale biological data. He's proficient in programming languages, developed tools like TB Profiler, NTM Profiler, and Malaria Profilers. He holds a PhD from London School of Hygiene and Tropical Medicine, and right now as an assistant professor at London School of Hygiene and Tropical Medicine. Judy, please, the time is yours.
Great, thank you very much. Okay, so I'm going to give you a talk, and it's going to mostly focus around the use of whole genome sequencing as a diagnostic. So obviously, I won't stay on this for too long, but we can see that there's a lot of different diagnostic methods. The conventional methods include obviously X-rays, smear microscopy, culture, and then we have molecular methods, and these include tests like the Gene Expert, the line probe, and others which rely on detecting potentially mutations or DNA in a sample. I'm going to focus mostly on this whole genome sequencing for this talk. So starting off, I'm going to talk about what makes a good diagnostic. There's a few characteristics. What makes a diagnostic useful is obviously sensitivity, specificity. We have the ability to provide a result in a rapid and timely fashion. The cost of the diagnostic is also very important. The point of care capability, so how close can you get it to the individuals who need it. The ability to detect drug resistance is extremely important for TB, as I'm sure you already know. And then obviously some more practical things such as the ease of use and training, standardization of reporting, and how easy it is to integrate into existing health systems. So because I'm going to talk about TB, I'm just going to a few slides just about the genomics of TB. So obviously we have a genome of TB. It's about 4 megabase in size. It contains all of the instructions to produce all of the proteins that it needs. And it's got 1 copy of this circular genome. No plasmids and no recombination. And that's quite important for the analysis that can be done using whole genome sequence. So in terms of the different technologies, the first generation of sequencing was Sanger sequencing, as I'm sure you already know. So that was used to produce the first genome of TB. So it was the H37RV strain. It's quite low throughput, so it doesn't work very fast. It's a high cost. And so following on this, we have the second generation technologies, such as Illumina, Ion Torrent, and these are high throughput and quite low cost. So, we sequence a single whole genome for about 45 British pounds. So it's decreasing in cost every year, and so it's becoming more affordable to do this. There's different sizes available, but generally the second generation technologies aren't very portable. And I guess that's where the third generation really comes in. And so this is a picture of an Oxford Nanopore MinION device. So that's about the size of a smartphone. And you plug it into your laptop and you can produce also similar data as second generation. And so they're more portable. The cost potentially is a little bit more expensive depending on how you set it up. But definitely the initial setup cost is also decreased. So just briefly on how we kind of analyze this data. So we have like a reference genome. When we actually get the data from these sequencing platforms, we actually get not a single genome, but we have many millions of short sequences that we need to basically align to a known standard. Then we can identify regions which are different, for example, here. So we can condense that into information about what our isolate contains in terms of its genomic content. And we can compare that against a different isolate, for example. So I'll talk a little bit about the applications of whole genome sequence in detecting transmission. And so for that, I'll give you a short intro on how we can do this. And so we start off, with a single bacteria with its genome. This is obviously a lot shorter than the real genome. But this obviously divides and gives rise to the next generation. And as it does this, it acquires mutations. So here you can see a difference between this sequence and its parent sequence. And again, the next generation, each of these divides. And again, by natural mutation, it acquires these differences. And you can keep going. And so you'll notice that as time goes by, these sequences start to differ more. So here we only have one difference in the first generation. So the next generation, we have 3, next 5, okay? So this is quite important because you'll notice that sequences which are closely related in time have fewer differences between them. So here, these have 5 differences because if you track back to their ancestor, it's the initial sequence. However, if we look at this 2 sequences here, their ancestor is I guess, shorter in time back, and we only have 1 difference between them. And this is the foundation of how we can identify transmission. So we can kind of build this up into this kind of tree-like structure, and this is called the phylogenetic tree. And so we can do this, and we've done this for thousands of isolates. So the latest study that we performed was looking at roughly 30,000 different TB strains, and it allows us to group these strains into clades. So groups of common strain types that share quite a lot of mutations between them. And so these clades can be thought of strain types, or perhaps you might have heard of lineages. So these lineages go from, I think, 1 to 9, and it allows us to identify quickly strains that are very similar. So if you have a lineage 1 strain and I find a different strain, I can quickly look up what's the strain type there. And if it's the same lineage 1, then it could be evidence of potential transmission. So these strain types are referred to as lineages. And one thing that we can do is if we find we have a certain lineage that is increasing in size in terms of its proportion, we can then look into this in more detail. And we can do some kind of transmission tracking using whole genome sequence data. And so you'll remember from before, genomes which are more similar are more likely to have arisen due to a closely related in time ancestor. And so here I just have a picture where I kind of add in sequences, and if these genomes are within a certain cutoff in terms of how many differences are there between the genomes, you can kind of link them. So here in this picture, we have the individual kind of dots or nodes or isolates, and I've drawn a link between them if they are less than 10 mutations difference between them. And so we can then start to say, okay, these are closely related. They might have been, well, they are around because of a recent transmission event. And we can use other metadata such as dates and locations to kind of fine tune this analysis. And so this allows us to identify potential large clusters where we can then start to say, okay, what's special about these individuals? Is it perhaps something that we can do to reduce transmission? So here's an example. In Thailand, a data set that we analyzed, if we identify through phylogenetics a cluster, then we can look at that cluster and identify the strains that are very similar. And then we can start to integrate other information, such as, what's the geographic location? Is there perhaps an ongoing transmission cluster somewhere? And so this is something that's super important in terms of stopping the spread of TB. And it's something that I guess can't really be offered by any other of the diagnostic methods. So transmission really needs whole genome sequence data to work. And so that's one super competitive advantage of whole genome sequence as compared to other methods. The other thing that's very important is the ability to detect resistance to drugs. And so obviously drugs are, the resistance to drugs are often acquired. In this example, I'm taking isoniazid. It's a prodrug. It needs to be activated by an enzyme called CATG. And its active form, it then inhibits INAJ, which is involved in cell wall synthesis. So if you get mutations in either CATG or INAJ, we can get resistance. And because we can characterize the whole genome, we can identify these mutations. And based on that, we can predict whether or not we have resistance. So we know for most of the drugs what the candidate genes are. So obviously these are first line drugs here and some of the second line drugs. And so we can look at these genes and identify mutations. And so this is some of the ongoing work is basically integrating many strains and identifying through statistical methods the mutations that are associated with resistance. And I guess some of you might have noticed that the WHO have recently released a list of accredited mutations that they are confident are involved in resistance. And so this kind of provides the ability to search for them and predict. And so this is a bit of an old slide now, but this is we're just looking at the predictive accuracy. I think that was back in 2018 of the list of mutations and comparing it to phenotypic methods. And so we can see for some drugs, the sensitivity is pretty good, specificity pretty good too. But for other drugs, it's not great. And there's two reasons. One is potentially that we don't know the mechanism of resistance yet. The other thing is that the phenotypic method isn't perfect. So we're using it as a gold standard, but we know it's not perfect. So errors in phenotypic methods should also be considered when looking at predictive accuracy. And obviously for newer drugs, that's an issue because resistance hasn't really, is emerging, but we haven't had that kind of backlog of strains stretching back in the years to identify these mutations. So this is an active area of research in how we can use sequence data to quickly identify mutations involved in resistance. One of the tools that I'm currently working on actually is to develop a system for that, where individuals could, contribute a genome. This gets analyzed on the fly and compared to all other genomes, and we can start to identify mutations that are involved with resistance. worth mentioning is also that we don't necessarily need to actually sequence the whole genome if we're looking just at resistance. There's a technique called amplicon sequencing, which we can use to amplify out certain regions and sequence only those regions. And so it turns out for drug resistance, we probably need about maybe 40 or 50 genes, as opposed to, you know, the 4,000 genes that are actually present. And so we can really reduce the cost of sequencing if we only look at the genes that are actually involved in resistance. So it's a lot cheaper than whole genome sequencing. It does require you to kind of do this amplification step with primers. But actually, quite recently, the WHO released a rapid communication on the use of these targeted next generation sequencing methods to detect resistance. And so it's kind of endorsed the use. There are a couple of different forms available and commercial kits already available. So Oxford Nano, which is the MinION device, has actually released a kit specially for TB amplicon sequencing. And so they're reporting 94% sensitivity and 99% sensitivity for detection of tier 1 drug resistance. So that's first line and some second line resistances. So they also report very low failure rates and actually can provide a result for almost 80% of smear negative cases. So it's quite an important step forward. And the WHO, I guess, is starting to support this targeted next generation sequencing methods, and have also, you know, released that mutation list as I mentioned before. So actually, maybe before I continue on, just to mention back on this slide is that some of the methods that we use to detect resistance here rely on comparing it to a phenotypic method. So we can only really detect mutations that cause phenotypic resistance. So there are some issues with detecting perhaps mutations that rely on or confer low-level resistance. Obviously, resistance is a bit of a spectrum. We have mutations that perhaps cause low-level resistance, also those which cause high-level resistance. And so methods that use these phenotypic tests as a gold standard really improve their performance if we analyze lots of sequences together. So the more sequences you analyze, the less you have that kind of noise of sometimes a sample being resistant or sometimes sensitive, depending on the test that you use. So that's something that's quite important. I think to stress that as we go into the future is to really being able to use all of the data that's available. And so to set up the infrastructure for that is quite important. So next, I'd like to talk a little bit about the other kind of parameters that include the ease of use and training and integration with health systems. So obviously, you know, the computer that I made this presentation on is quite standard. It's got some memory, some basic CPU, and some disk space, but it's quite an average computer. And so, unfortunately, most bioinformatics software has been developed for these high-performance computing environments, and so that won't run on your laptop. So what we did is we wanted to make a tool that can analyze next generation sequencing data, but also do it on very kind of commodity hardware. So something that doesn't use much resources, is quite fast, can take input from different platforms, and can ideally, based from whole genome sequence, predict lineage, predict drug resistance, and also has a very flexible output and is quite extendable. Unfortunately, most bioinformatics software is run on something that looks like this, the terminal. So it doesn't have a graphical interface where you can like point and click with a mouse. You have to type in commands and it will do the job for you. But it does require quite a lot of expertise to get this software to run. And that's one of the things that has been a barrier to the application of WGS. So one of the things that you can do is obviously training. I've just put up a slide here of a training workshop that we run in Zimbabwe a couple of weeks ago, is where we actually did the training in terms of the lab-based science to perform the sequencing, but also the training how to actually use the terminal and run these informatic softwares. So that's one step that you can do. The other thing is that we can try to do is improve the ease of use of these tools. And so ideally, we want to put in all of this data and just get some very easy to reports. So I've developed a tool called TB Profiler and also developed a web interface for that. So now you can basically just drag and drop your files into this website, and we get some information on, the clustering, identifying potentially transmission between different samples. We also get information on drug resistance. So here we've just seen a report where it lists the mutations it's found that are known to be involved with resistance. And so we're getting closer to having a test that's very powerful, very easy to use. The last thing that I'd like to touch on is the integration with health systems. And so the thing I'm focused on here is to prove. So here included a report that I've developed together with individuals from the Thai Ministry of Health. And it's a report that comes straight out of TB Profiler, and you can just zoom in a little here a bit. Provides a report that's actually, based in Thai, and is following the specifications that the health ministry there requires from the tests. So at the moment, informatics tools, I think, produce output that's very good for other, bioinformaticians and genomics experts to understand. But I think there's a little bit of a barrier between that and actually a clinical report that can go out to clinicians and summarizes the useful information. So this is a kind of a rapid and area of development in terms of actually applying these tests. And so I think I'll stop there, just on time, I hope. And hopefully I've touched on some of these characteristics and why whole genome sequencing could be quite useful to roll in, together with traditional methods. And so thank you very much.
Thank you, Jody, for your very interesting presentation. But since we have to postpone this plenary, since we will have a closing ceremony first, and then after that, since Bapak Imran, Director, have to have to leave Jogja, so this session will continue after the plenary closing ceremony.
Yeah, Ibu, please do not, please remain on the stage. We are very sorry, but there are some changes again. We have received the newest information that it should be continued to the next speaker. Yeah, then after that, we will proceed with the closing ceremony. So please, Ibu, continue with the session. Yeah.
Oh, we can continue the session.
Yes,
okay.
Absolutely. We are very sorry about this one, Ibu.
Okay. Thank you very much, Pak Imran. I know that Pak Imran will wait for the session because it's very interesting and it's very important. So the next speaker will be presented by Dr. Fuad Mirzayev. He possesses a diverse background in public health and global initiative. His professional journey encompasses roles that demonstrate his commitment to addressing healthcare challenges through project management, research, and international collaboration. His involvement in critical projects with the WHO focus on tuberculosis and public health issues. And right now, his dedication to enhancing healthcare system and outcome. So, Pak Fuad Mirzayev will present to us about certain tuberculosis treatment regimen. So, please the committee to present the video from Dr. Fuad.
I'm leading the treatment team in the Global Tuberculosis Program of the World Health Organization in Geneva. During this talk, together with my colleagues, Medea Gege and Denise Falzon, we will present the most recent updates of the WHO Consolidated Guidelines on Prevention and Treatment of Tuberculosis. A few slides to focus on the details of treatment of drug-susceptible TB. 2022 drug-susceptible TB treatment guidelines consolidate all valid recommendations from previous guidance and add 2 new recommendations on 4-month treatment regimens in adults and children. It is important to note that 6-month regimen that is widely used worldwide remain to be recommended. This is the regimen composed of isoniazid, rifampicin, pyrazinamide and ethambutol for 2 months and isoniazid and rifampicin for subsequent 4 months. It applies to most of the patients suffering from TB. The new 4-month regimen for patients 12 years and older consists of isoniazid, rifampicin, moxifloxacin, and pyrazinamide for 2 months and isoniazid, rifampicin, and moxifloxacin for subsequent 2 months. This regimen was recommended after review of the evidence from major multi-country clinical trial, so-called Study 31. Another new 4-month regimen recommended is the isoniazid, rifampicin, pyrazinamide, and ethambutol for 2 months, and isoniazid rifampicin for another 2 months. This regimen can be used in children fulfilling the criteria of age between 3 months and 16 years old and the definition of non-severe TB, which is in this case peripheral lymph node TB, intrathoracic lymph node TB without airway obstruction, uncomplicated TB pleural effusion, or post-bacillary non-cavitary disease confined to one lobe of the lungs and without any miliary pattern. Those not meeting inclusion criteria should receive the standard 6-month treatment regimen. Ethambutol can also be omitted in certain situations.
Hello everyone. It's my honor to speak at this event on the updates of the WHO guidance on treatment of drug-resistant tuberculosis. In early 2022, the WHO published the public notice to inform the community on the upcoming updates of the DRTB policy. This was followed by organizing the GGG in February and March, which included 10 PICO questions and more than 27 experts from all over the world. The data used to review the existing recommendations was based on the new evidence provided by MSF from the TB practical clinical trial conducted in Belarus, Uzbekistan, and South Africa. A successful treatment outcome was achieved in more than 80% of participants at the end of treatment for all 8 investigational regimens, and with 89% treatment success in people arm of the TB practical. Important to note that comparator regimen for this trial was locally approved standard of care, either 9 months or longer regimen. Another set of evidence were provided by TB Alliance through ZENIC study, which was a randomized controlled trial conducted in Georgia, Moldova, Russia, and South Africa. The ZENIC study investigated 4 different arms of the 26-week BIPAL regimen with different doses and durations of linezolid. The updated WHO recommendation states that 6-month regimen, known as BPAL, is suggested to be used in RR and MDR-TB patients rather than 9 months or longer regimen. The BPAL regimen may be offered to patients in the following situation: pulmonary TB, or all forms of extrapulmonary TB except TB involving central nervous system, osteoarticular TB, and disseminated TB. Patient whose age is more than 14 years, no known allergy to any of the BPAL component drugs, no evidence of resistance to bedaquiline, linezolid, or pretomanid, all people regardless of HIV status, no XDR TB, and indeed patient is not pregnant or breastfeeding. In the BPAL regimen, pretomanid is administered at 200 mg once daily. Moxie is given in a standard dose, and linezolid is administered at 600 mg once daily. There are 2 types of doses for bedaquiline. The usual dose, 400 once daily for 2 weeks, followed by 200 mg 3 times, and 200 mg daily for 8 weeks, followed by 100 mg daily. The last based on Danix trial and considered as an alternative option for patient convenience. The duration of BPAL is strictly 6 months, whereas BPAL can be extended up to 9 months based on the culture conversion. Ideally, missing doses should be avoided. However, if doses are missed, any interruption of more than 7 days should be made up for by extending the treatment regimen. Particular attention should be given dosing and duration of linezolid within BPAL regimen. The usual dose is 600 mg and it is preferred for the entire duration. Dose modification is acceptable only after the first 9 weeks of treatment. It is possible to reduce the dose until 300 mg in case of peripheral neuropathy grade 2, and if there is grade 3 or 4 or any grade of the optic neuritis, then patient qualifies a permanent suspension of the linezolid and therefore the entire regimen. The BPAL regimen is proposed as a standard package, and usually no replacement of any component of medicine is recommended. However, bedaquiline or pretomanid, if bedaquiline or pretomanid is permanently stopped or linezolid is permanently discontinued during the initial 9 consecutive weeks of treatment, the entire regimen should be discontinued. As for the 9-month regimen, the 9-month all-oral regimen is suggested to be used in patients with RR and MDR-TB in whom resistance to quinolones has been excluded. This is a new recommendation where the 9-month regimen was compared to the longer regimen of 18 months, and therefore the 9 months all-oral regimen is recommended in 2 variations, with etionamide or with linezolid. Evidence supporting the updated new 9-month regimen were obtained from the programmatic data of South Africa. Therefore, the comparator was previously recommended etionamide-containing version of the 9-month regimen. The 9-month regimen may be offered in the following scenarios: patient without resistant to quinolones, without extensive TB disease or severe extrapulmonary TB, patient with less than 1 month's exposure to bedaquiline, quinolones, etionamide, linezolid, or clofazimine. It can be offered to patients regardless of HIV status, and children and adults without bacteriological confirmation of TB, who has a highly likelihood of MDR or RR TB. There are 2 variations of this regimen. The etionamide variation involves initiation of bedaquiline, levoormoxy, clofazimine, etionamide, ethambutol, INH with high doses, and pyrozinamide. And the second version, linezolid variation, which includes all the same medicine except that ethionamide is replaced by linezolid and therefore has broader eligibility than the previous version. The 9-month regimen should be implemented as standardized package. It's not advisable to change neither the composition nor the duration. However, it is possible to use protonamide instead of ethio. Also, bedaquiline can be extended to 9 months. And in general, linezolid is only given for 2 months with a full dose of 600. However, if during the first 2 months the doses are occasionally missed, only if these are occasionally missed, it can be added to the end of the second month. In case of intolerance during the first 2 months, patients should be switched to a new regimen. Now, regarding the longer regimen, the existing recommendations remain valid and there are no changes. However, longer regimen remains the last resort for MDR and RRTB patients. The only news here is that previously mentioned age restrictions for bedaquiline and delamanid have been removed, which makes this medicine available for all children of any age. In summary, VPAL regimen is a novel and new shorter regimen for a majority of RR MDR-TB patients, whereas 9-month regimen considered as an alternative possibility for certain patient subgroups. The longer regimen, therefore, is the last resort. When choosing the regimen, several factors, as outlined in the table below, have to be taken into consideration. Based on all above-mentioned evidences, the WHO has updated the operational handbook and guidelines. The content and main changes are in the chapters highlighted in red. Just to note, the updated operational handbook, in addition to the content, also has 3 web annexes as featured in the slide for more detailed information.
The next slides relate to the use of shorter TB preventive treatment, or TPT. My name is Dennis Falson and I work at the WHO's Global Tuberculosis Program in Geneva. Several TPT regimens are included in the WHO guidelines, including options to protect from drug-resistant TB. Some regimens, asterisks in this slide, are strongly recommended based on the evidence of potential benefit to harm. Isoniazid monotherapy for 6 or 9 months has been used widely as TPT for several decades. Its length may be increased to 36 months or more in people living with HIV in areas with intense TB transmission. The use of rifampicin or rifapentine allows the duration of TPT to be reduced down to even 1 month, or 12 doses over 3 months. Shorter TPT regimens are shown in red on this slide. Increasing access to rifapentine will help to increase coverage of TPT. By June 2022, 78 countries reported ever using shorter rifapentine-containing TPT, including in trials or subnational projects. In 2021, 52 countries reported starting over 185,000 individuals on shorter TPT regimens. In 34 of these countries, rifapentine-based TPT was used, mostly 3HP, while 42 countries reported using a rifampicin-based regimen. 17 countries or territories are known to have registered rifapentine. There are now 3 quality-assured generic rifapentine products on the market. Rifapentine single tablets in 150 mg and 300 mg dosage, and a fixed-dose combination tablet of 300 mg rifapentine and 300 mg isoniazid. The price on the GDF catalog for the 3 film-coated tablets is shown on this slide. Work is ongoing to develop pediatric formulations and an FDC. In May 2022, WHO pre-qualified its first rifapentine isoniazid generic FDC, the 300 mg formulation, produced by McLeod's Pharmaceuticals Limited in India. In the same month, the Global Fund announced that rifampicin 300 mg tablets and rifampicin isoniazid 300 mg FDC, both manufactured by Lupin Limited in India, had been recommended for use by the expert review panel for 1 year. In August 2022, partners announced 2 new agreements with McLeod's Pharmaceutical Limited and Lupin Limited to lower the price of rifampicin-based TPT in low-resource countries. 3HP would be made available at a ceiling price of $14.25 from both manufacturers, and rifampicin 300 mg single tablets used in 3HP and 1HP would be made available from Lupin Limited for $33.9 per 100 tablets. The new prices are available in 138 low and middle-income countries, including those with the highest burden of TB globally. By September 2022, there were at least 22 clinical trials to evaluate drugs and drug regimens for the treatment of TB infection. These include trials for the prevention of drug-resistant TB among high-risk household contacts of TB patients with multi-drug or rifampicin-resistant TB, and trials to assess how to optimize the administration of short-course TPT for very young children and people with HIV. The use of long-acting technologies to administer TPT has the potential to significantly improve the delivery and impact of this important public health intervention. For example, an ideal long-acting treatment could consist of a single dose that could be administered in a clinic, that is, a one-shot cure for TB infection. Interest in long-acting formulations for TPT has gained considerable traction in recent years. This article presents an overview of the specific considerations and current preclinical advancements relevant to the development of long-acting technologies of TB drugs for the treatment of TB infection. For more information, you can access the WHO TB Knowledge Sharing Platform on these sites. The platform includes panels on consolidated guidelines, operational handbooks, training catalogs, and research and innovation. We thank you.
Okay, thank you for all team from WHO. So I would like to make a summary from this session. I know there's many participants want to ask question, but since we have very tight schedule, maybe I can make a summary that we know that TB management is very difficult, especially if we're facing to the drug-resistant tuberculosis. So the precise DST pattern prior to treatment is very neat, and it will be help if we use sequencing in the future or near future. And another problem in drug-resistant tuberculosis treatment is that we hope for ideal treatment with short treatment, high efficacy, less side effect, and good adherence. But it's still difficult, so hearing about the new regimen that only 4 months and 6 months for drug-resistant TB, I think it's a hope that will improve the success treatment, especially for DRTB and DSTB in the future. Thank you for your participation in this session. So we can continue to another session. I close this session. Assalamualaikum warahmatullahi wabarakatuh.